So let me introduce Dr. Robinson, our keynote speaker. Dr. Robinson is a known expert and highly distinguished person in this area, in this field. She's an associate professor in the Department of Obstetrics and Gynecology here at Duke. She joined Duke in September 2021. Am I correct? Well, I'm glad, because now she's a Blue Devil. Prior to that, she was Tar Heels. Am I correct on that? But anyway, so her specialization is in epidemiology, quantitative methodology for studying health inequalities. Dr. Robinson.
Thank you so much. That was such a nice introduction. I'm really happy to be here. The talks have been really amazing. I love thinking about data and how to improve data to try to understand health. And so everybody's work is really inspiring. My talk is actually going to be less technically involved. We've had a lot of formulas and we've seen a lot of people really dig into how they're trying to improve work. But I hope that for those who come from a discipline where you weren't necessarily trained to do a lot of statistical analysis, you will get, maybe a nugget or two that helps you with your work. And then also, I'm going to really focus on some big picture questions that I think all of us can think about as we move forward. So this is a very multidisciplinary audience. And I'm actually going to start with a question that's grounded in how I come to the field. I think we need all kinds of people, and we all bring not only our specific training, but we really bring often an orientation to the work, the kinds of questions we want to ask based on our training. So I'll kind of start with my training. I am an epidemiologist. I am also showing a slide of my colleague, which is very odd. For those of you who know her, she's a social epidemiologist who, has been someone who's always been ahead of me, who I really admire, who works in dementia and aging. And she also likes to ask people provocative questions. And so about 10 years ago, she asked me, why are you an epidemiologist? And I've actually thought about that question a lot. And it's made me think about the way I approach my work, and it's actually shaped how I approach my work. She was asking specifically why I'm an epidemiologist and not in another quantitative field where you can apply your methods to health. So there are sociologists who've talked, health demographers, economists, health services researchers. A lot of us ask questions that, are all relevant to our disease outcome, and we come at it with data, but we bring slightly different orientations. And so, Maria and I participated in a program called the Robert Wood Johnson Health and Society Scholars Health and Society Scholars Program. And this was a 2-year program that brought together people from a lot of different backgrounds who were all really interested in improving population health at a large scale. And when I thought about this personally, my answer was that I appreciate the discipline of epidemiology grounded in public health, because it has more of an emphasis on the practice-based and intervention-oriented side versus some other fields that do a lot of quantitative analysis and might be more looking at big theories that they're trying to develop and test, like the sociologists who provide us so much grounding and even how to think about the world and how to frame questions. But in a practice-oriented field where the possibility of action to improve population health is your guiding star, you really get into some of the details and the practical aspects of that guide kind of what you're doing. And so I'm an epidemiologist because I find the orientation to intervention and practice to be grounding, intellectually challenging, and I feel like this pushes me in my research because otherwise I just love playing with data. And so when I think about my job as an epidemiologist, I really think about it in terms of 3 questions: to choose important research questions, to ask specific research questions, especially as a quantitative scientist, and to do analyses that answer these questions. And so this may seem trivial, but each of these is actually challenging. And so it also really makes it fun. And so I'll talk about more what I mean by each of those, and especially in the context of racial ethnic equity work. So then a separate question is, what is my job as an epidemiologist studying racial ethnic differences in health? I would say that the same big questions matter, but it does shape my work. There is something particular about approaching this kind of work. As an epidemiologist, I was trained to say, is factor X associated with factor Y? And that's often a question that you're thinking about kind of in the general average effect in a population. But when you go down to a separate question, well, what factor X might cause a population difference between group A and B? It's a harder question. Although we see from our friend Larry that sometimes people are like, I know, I have the answer. But in a lot of my work, it is a more complicated question. So you take all the complications of trying to understand, at the average margin, what is the relationship between X and Y? But now you're adding on a different question about, okay, well, what factor that has a relationship with factor Y can also be explaining this group differences? And it is another level of complexity. And most of the questions I ask are of that form. The form of what factors X cause outcome Y to be higher in group A1 versus group A2. So the first thing that I have to do my job well is to choose important questions. And you can interpret this a lot of ways, but I think the way I think about it is to avoid tunnel vision, to make an informed choice and incorporate all the important information. You can't study everything. And that's why we need teams, but we also sometimes have to prioritize. What are we asking and what are the alternative hypotheses we're considering? And so with any big question you're asking about, why does this happen? Why am I observing this pattern? You have a range of possibilities that could explain that association when you're doing quantitative work. And so you have to start by thinking of that range of possibilities that map onto things that are more or less important and that translate into something that actually matters. And so many questions that fall under this umbrella are possible. Genetic susceptibility, behavioral choices, legal and policy choices, institutional challenges like limited healthcare access. And so I think when I think about the questions I want to narrow to, often it's guided by the science, like what seems like there's a big base I can build on that's going to actually get us somewhere to know something as a community, but also what can get us into the space to have actionable solutions. Now, I'm not saying to limit to small things. I think sometimes when people talk about things that are actionable, they're like, well, let's just limit to these things that are right on the cusp of being done, that are kind of easy wins. That's not what I'm saying. I'm also not saying that it has to be kind of small and trivial. I love the big ideas. You can have a big idea that has a clear line to something actionable, but you really have to think deeply about that counterfactual world in which you can address this, and to really think deeply about, if I do this, how is it going to move the needle? And so I'm going to get a little theoretical here. One big way that I help try to think about the range of possibilities to consider when I observe a pattern in data is to really get grounded in my theoretical orientation. And I think this is where the theory people really help us. I think sometimes, depending on the field you come from, you might not even realize your theoretical orientation, because maybe in your field, they didn't talk about a theoretical orientation. They're like, you're in the lab, do your pipetting. I haven't done much lab work, so I'm sure that is a gross oversimplification. But when I think especially about the causes of racial disparities in health, I think we all have a tendency to go towards certain kind of explanations. There's a long history in this country of going towards genetic explanations. And so Dr. Brown in his talk had that lovely graph from Dr. Hardiman about kind of the possible set of explanations you can have. And that's an enduring tradition in the United States that's still very present, that when you think about Black-white differences, kind of some people are just going to go towards the genetic determinism. And so that kind of shapes kind of the questions they go towards and the alternative explanations that they see. But I'm firmly here. I'm more on the social environmental determinist side, but with definitely thinking about how the social and environment gets embedded, gets under our skin and really influences our biology, that these social and environmental and biology are not separate, but they're very intertwined with the upstream influencing the downstream. And Nancy Krieger has popularized this idea of the social and environmental getting under the skin. And that's why you need people, all the way from the molecular to the environmental because of those interconnections. But this becomes important when you analyze your data. So I do a lot with gynecologic health. And I've done some work with the effect of taking supplemental hormones during menopause and the menopausal transition. And so in one of the studies I saw, there was a big racial difference. Black women who took hormones actually looked less likely to get breast cancer, whereas white women who took hormones looked more likely to get breast cancer. And so people saw this and came up with all kinds of explanations. And we did a set of analyses where we said, well, not all hormones are the same. There's been some work that shows that combination, progestin, estrogen actually increases breast cancer risk, and estrogen only decreases risk. So we said, who's taking what? And this is determined by who's had a hysterectomy, which is a whole nother racial difference. And by the time we unwinded it, we said there's a racial difference here, not because the biological response is any different between Black and white women. It's because Black women are more likely to have early hysterectomies, which is its own thing. If you have an early hysterectomy, you don't need to take combination hormone therapy. They're more likely to take the estrogen-only therapy or to not be taking menopausal hormones. The white women were more likely to have a conserved uterus and to be taking the combination hormones. This is very in the weeds for people who don't do gynecologic health. But often when I see a difference, I think why? And I have to think, what are the range of explanations? Because there might be some hypotheses that come from genetics. There might be some hypotheses that come from health services. There might be some hypotheses that are more psychosocial. I can't know everything, but it's important for me to know I'm going to tend towards these kinds of explanations and to be in conversation with people who can make me see the things I might not see as far as competing explanations. And I think it makes our science stronger to always be thinking about competing explanations that might not immediately come to mind. The second thing I think is my job is to ask specific questions. So a lot of you here are kind of grounded probably in a counterfactual framework with doing quantitative work, maybe not, but this is a very popular way to think about adding some kind of rigor and structure to our quantitative work. The idea that, you're trying to think about making a model that tells you if I flip this switch and I make everybody exposed or unexposed, what would happen in the population? That is, some form of that. And it kind of gets you to mimic an RCT. But to get that, your question has to be super specific. Just like with a randomized clinical trial, your intervention is very specific. You can't be kind of hand wavy, like, oh, if I maybe I'm nice to people and I meet with them, maybe I meet with them once a month, maybe I meet with them 3 times a month. Like, you can't do that. They're like, you have to be specific. You can't get an answer unless you're specific. And I think this is a big challenge in work on racial ethnic differences. I think a lot of people are like, this matters. I see the difference in the population. I want to kind of try to understand it. I have a race variable. I'm going to put it in my model and see what happens. And then you get, an estimate. But often it's a little hand wavy and vague, kind of what the estimate means, even the idea of what does race mean in the model? A lot of my work is what does this variable even mean in your model? What does it mean to have adjusted for these other things? What is the counterfactual world you are imagining? Does it even map onto reality in any way? And so the kind of specificity of that question and interpretation is something that can seem trivial, but it's easy to overlook. And so I have talked about potential outcomes and randomized controlled trials, and race presents a real problem there. Because we're not like, oh, we're going to go out and just change everybody's race. That's not what we want to do, versus other things we might put in our model where we really do just want to change it, like if we're looking at a drug or something. And so I think we have to think carefully about when we're looking at this variable, what is the counterfactual we're imagining? And I think we should imagine counterfactuals. We should think, what if policy was totally different? We should think about natural experiments like changes we saw after the 1964 Civil Rights Act. These things do move, they have moved. And so when we think about how to interpret our effects, we really have to think carefully about, what am I even asking? And so my point here, oh, sorry, part of my little nosebud on my glasses has fallen. I wear my glasses all the time. Let me adjust myself. Having data is not enough. We have to really think carefully that we have many options in terms of study design and analysis. And we have to think carefully about it. Even something like education. You know, what does it mean to have a high quality education? Is it about years? Is it about the skills you attain? Is it about, I don't know, the environment? Like being in a school can be a really positive environment or a really negative environment. And so I love trying to push on the specificity of our research questions. And then the last thing I want to do in quantitative science is to actually do analyses that answer the questions. And again, this seems trivial, but it is not always obvious. There are people who sometimes do analyses that don't really address their questions. And I think it's easy to fall into that trap. You're like, well, I've put together data that seems relevant and I'm like doing a lot of fancy stuff, but like, does it really answer your question? And I think matching the study design and methods to the thing you're trying to get at is really important. But that requires number two, which is really knowing what you're trying to get at. And there's so many cool methods. It's so great, but also it can be bewildering and something can seem good, but not really get at what you want to get into. And so I think we have to really sometimes be a little bit wary of complexity. Sometimes the most complex tool is exactly what you need, but sometimes complexity can be a barrier. It can be a barrier to doing more interdisciplinary work and to people entering the field. It can also obscure the fact that maybe the deep thinking has not taken place about whether the research question is important enough or precise enough. And so I'm briefly going to talk about a study, not even really a study, a commentary I wrote that is very simple. Like it talks about some regression models and it has some pictures in it. But it's accessible, and so I like talking about it. And so for people who are kind of beginning learners, I think it can be a nice paper. And this really thinks about when you have surveillance data, where you have a really good sense of who your population is and you're trying to understand disparities. You can think about three questions to guide, like, do I think there's a disparity here? And do I think this factor contributes to it? And so in this paper, I actually comment on another paper. And I'm not doing this to disparage this other paper, but I just thought it was a really good example of a team that had really done an analysis using high quality data and came to a conclusion that I think is the wrong conclusion. And I like that they were specific about what they thought the point of it would be. And so I'm using it as a teaching example. So this is a paper from 2013, published in Hypertension. And I like it, again, because it was very explicit about what they thought their data showed. And so they say that based on their data, this is the end of the paper, in clinics, health providers need to further improve care for diabetes mellitus, so DM stands for diabetes, and blood pressure in non-Hispanic whites, while maintaining quality work in non-Hispanic Blacks and Mexican Americans. And so this is a bit odd because diabetes tends to have higher morbidity in Blacks and Mexican Americans, and they're saying, no, we need to kind of focus our efforts on making care better for whites and just status quo for Blacks and Mexican Americans. And so, you know, it's a bit eye-catching for anybody who works in cardiovascular disease. And so one of the reasons also is just because, you know, in a health disparities framework, often we are focusing on populations that are the more disadvantaged for targeting of resources. But really here, I'm really focused on the analysis. So in our paper, we say, if you're a researcher who, you know, just has access to very basic descriptive tools, maybe some simple regression modeling, and you have a data set that you think has a good sampling of people, and you want to understand, is there a disparity here and might this factor contribute? You might ask, is the disease burden in the target population greater than in the other population? Which is really about outcome patterns. And we've talked about that so much here. And a lot of this is about measurement. I think in ADRD, the measurement challenges. Are we talking about subclinical disease? Are we talking about diagnosed disease? Are we talking about how people perform on tests? All of those measurement issues come into play. So even the question about whether the disease burden is greater in one population than the other can be a hard question to ask because it depends on your sampling and it depends on your measurement. The other question is whether the factor you're thinking could be contributing to the disparity, is that factor greater in the target group than the other group? And we've talked about a lot of potential factors today, structural racism and other biomarkers and genetic factors and healthcare factors and personal factors. And again, measurement comes into play, and having a really good sampling to be able to understand the distribution of these factors in a larger context for one group versus the other. And the last question is more about kind of interactions. Do we see different relationships of this factor, this exposure factor, this factor of interest into the different populations? And for a lot of novice researchers, I'm going to argue that's where things can kind of go sideways. So I'm actually not going to talk that much about kind of the differences in outcome, because basically here, the diabetes, which is the factor that's being considered, was indeed greater. It was greater in the Mexican Americans and maybe a little bit greater in the Black population, especially at the end of the time period, than the white population. And again, the recommendation of the paper is we need to target whites. And then the exposure. I'm going to skip through this. But also diabetes, again, this is the factor that the authors end up saying we need to target better control in the whites and status quo for the Mexican Americans. Diabetes is also more common in this data in the non-Hispanic Blacks and the Mexican Americans. So now we have something where, the outcome is uncontrolled high blood pressure. So the outcome we're looking at, uncontrolled high blood pressure, is like the least bad in the white group. The exposure, diabetes, is also the least bad in the white group. So how do we end up with this idea that we really need to target control of diabetes in the white group? And so I draw this picture here because it kind of gives you a sense of like the distribution of maybe the diabetes in the different groups, the relationship of the diabetes to the uncontrolled blood pressure, and how they got there was by basically misuse of an interaction term. So this is the stratified analyses where the relationship between diabetes and hypertension is greater in the white group than the Black and Mexican American group. And so they get a significant interaction term. And the relationship is the strongest in the white group, so they say we need to target the white group. And this is like a little bit of a kind of like epi 101, 102 thing, but I think it is important because this was published in a pretty good journal. Like there was peer reviewers, people looked at this, and I think it just shows that just because we have data doesn't mean we know how to properly interpret the data. Because here, if you have Mexican Americans who have more uncontrolled blood pressure and more diabetes, yes, the slope of that line is not as steep as in the non-Hispanic whites, but the burden of disease really is. And they really need more care and targeting to bring down the burden of diabetes and uncontrolled blood pressure in their population. This was an example just to talk about, like, it's not enough just to have your data, you also need to really understand it. And I gave a pretty simple example. And so there has been talk of more advanced methods. I think we would love to have a model where we just put everything into the model and it's like, this is the thing that causes the health disparities and that we should target. And so I've actually done some work in mediation analysis, and it was definitely presented very well by Igor. But sometimes I do get a little skeptical because it does, sometimes the fancier the model, the more assumptions you need. And the assumptions can be really hard, especially when we're thinking about racial ethnic differences. Do I believe that I've accounted for all the factors that differ between, you know, a disadvantaged racial group and another group? Like I haven't, but even if I could, and I put that all into the model, does that have relevance for the real world? Because now I'm imagining a world in which everything is equal between the two groups, but that's not true. So I'm saying, oh, what if everything was equal? All racial disparities were gone, and I changed this. What effect would that have? Like, is that the right question? And so I don't necessarily have the answer. A lot of what I do is focus in on one particular contributor and try to do a study design that really gets at establishing some feasibility and plausibility instead of like a precise estimate of like, this is the specific contributor to this, because I actually don't believe we have the data or methods to get to that. Often I'm trying to say, is this even plausible? So I have some work now in understanding why Black women get hysterectomies at such young ages. And so there's two big camps. Like one is that there's just, they're being overtreated. They, you know, even when their symptoms aren't as bad, maybe they're being overtreated. Another big camp is like, no, they just have worse disease. They're getting so much surgery because they have worse disease. And so these are simplifications, but these are kind of two extremes. And we really need to kind of figure out which is right. They're incompatible. You know, one is more right than the other. And depending on which one is right, the research and practice needs to move in one direction or another. So a lot of my work is I like thinking about, like, what are the really big opposing theories and camps? And can I narrow down which is more likely to be right or not? So at least we're starting to move more in the right direction. And, you know, yes, I won't talk about my specific work that much, but I think choosing important questions can be difficult, but it actually is really fun. And I think it moves us towards an interdisciplinary approach because we need colleagues to say, well, have you thought about this alternative hypothesis or this alternative hypothesis? And that helps us ask sharper, better questions. We also need to ask specific questions, which is really hard with race ethnicity. And another thing is you can often get a result because the construct of race ethnicity is tied to so many factors, like your model's gonna spit out something. And I think that actually can make people be less rigorous because it's kind of, sometimes you can get something, but is it specific enough? Is it really moving you? And then to do analyses that answer those specific questions. And it is really easy sometimes to see a model result and kind of forget where you started, forget the big picture of what you're trying to do and not get to the right place. And sometimes the analysis that moves you forward might not be the fanciest analysis, and it might not give you a precise estimate, but it's going to give you some proof of principle about, is this paradigm more important or this paradigm more important? And I think often that can be really powerful. These are my acknowledgements. I started this work a really long time ago, so I have like my K award on here. And yeah, I love talking to everybody, so hopefully we have some time for conversation. Thank you.
Perfect. So we have time for questions.
That's fine. Here already. Could you please tell us more on your paper with Professor Vanderwill?
So that was a paper. So I think that paper was trying to accomplish a few things. I think that was 2014, maybe in epidemiology. And I was actually responding to the paradigm in a lot of epi literature where people would have a race variable in a model and put in covariates and see how much the estimate changed. And any remaining coefficient for that race variable would be like the race effect. And I think there's a few things I don't like about that. One is that often that race effect would be interpreted as some very hard and fast biological thing. Well, like, we looked at everything else and this is left. So this is like the race effect. And often that was very much like, what is it? But it seemed like even if it wasn't explicit, it was some kind of interpretation of some kind of inborn biological or genetic effect. And so as somebody trained in causal inference and trained to think about what does quantitative data mean, I'm like, I don't think it means that. And so what we did is we really tried to put forth an idea that this race variable, which I think about as like a marker of social group membership, it's a way of like kind of categorizing people in our country, just like you might categorize people by living in a certain state. So I might ask, is Washington state different than New York? That's a question worth asking, but like, it's a complicated question because the differences between those groups are like a bundle of things. And so I said, race ethnicity, also this variable is reflecting a bundle of different things. And so when you see this difference in the naive analysis, it can reflect a lot of different pathways. And so some of that paper was pointing out those pathways. And we said causal mediation analysis could be a way to think about deconstructing these pathways. And we put forth 2 interpretations. Well, first of all, we pointed out there's a lot of assumptions you need to do a good mediation analysis. I am skeptical that we get to the threshold for meeting those assumptions in many scenarios, because it's like really rigorous, no confounding assumptions, especially if you want to do the strong interpretation of the model that, you know, this explains the race effect. You know, when we talked about that as the strong interpretation that you could get out of this causal mediation model. But then we also talked about a weaker interpretation, and I hate that it's called weak interpretation. I think it's the better one because it has weaker assumptions. And I think weaker assumptions are easier to meet than stronger assumptions. So I prefer the weaker model. And so the weaker interpretation is, instead of thinking about this as like a race effect, some like inborn trait that is universal to those in that racial classification, you know, I really think the weak interpretation is better because it's more thinking this is a group of people and we are looking at, you know, some average difference among this group of people and this group of people, and probably there's a lot of overlap, but there's a marginal effect. And let's try to understand what's contributing to this kind of marginal effect over this group of people. So since that paper, there's been so much movement. People like, why am I forgetting his name? Chanel Howe has done some beautiful work. She's an epidemiologist. I'm just going to name epidemiologists because I know them better. John Jackson has been doing beautiful work. And so, you know, like, I don't think that paper is the be all and end all. I really hope you read newer papers that have cited our paper, because there's been a lot of more methodological development, and that makes me really happy. And I think there has been a recognition of this idea of like the vague race effect that's biological is not rigorous. And I think people are more trying to untangle what those group differences mean. So that's my summary of the paper. I don't know if that addresses your question.
Yeah. So Dr. Brown, you have a question?
Yeah, I was going to raise a question. You may have just answered it, but I wonder if you could,
if there are any examples of substantive empirical papers that you feel like have done a pretty good job. Because I know some of these are more like methodological pieces, you know, the Van Wheel, John Jackson work. And I wonder if there's some substantive empirical papers that you think have actually done a good job of mediation analysis.
I'm going to pass. I don't read as much as I should. I tend to be kind of a little bit skeptical, and I don't do as much reading as I should. I actually have a paper. I sound terrible. I have a paper that was rejected recently where we actually looked at racial differences in breast cancer incidence with a focus on hysterectomy and hormone therapy. And I made the argument in this piece that, like, we know a lot about breast cancer. I think to do a good job in a mediation analysis, you need to be in a field where you know a lot. Like in ADRD, there's a lot of things we don't know. Like, do we feel like we can do a really strong mediation analysis? Are we so sure about every specific pathway? I think to do a good job with this kind of work for most questions, if you're really trying to satisfy the no confounding assumptions, you need to be in a field where like each part of the mechanism is really well defined and has strong causal evidence. The paper was rejected, so don't take my word for it. There's probably other great things out there.
So, but is causal mediation analysis still your favorite approach?
It's not my favorite approach. I like it, and I think it should keep developing, but I think people need to figure out like when is the right time to use it. I tend to go more towards trying to think about study designs, using more study design versus analysis. I think sometimes trying to power through with like more adjustment, whether it's covariate adjustment or weighting for these complex questions can be really tough. But I think sometimes you can use a really nice study design that helps you understand, like, are we leaning more towards this paradigm or this? Even though I still do a lot of regression modeling, but this is kind of in the weeds.
Any other question? I think you, please go ahead.
I have a potentially provocative question.
I love a provocative question, Casey.
Do you think we should be doing Black-white disparity research? I feel like we know there's always going to be disparity that exists. If you do white versus Black, there will be a difference, especially when it comes to health. The cultural bias exists everywhere, and a lot of that is due to, racism that exists that we've been talking about. So why not, I think that's the question. Do you think we should be doing disparity research? But then also, why not focus on within group? Because again, within our own group, we're heterogeneous. That's how we've actually identified so many established biomarkers for the white community, because it's been focused on the white. But why not start to do the same thing within our community?
And I think about that under the umbrella of sometimes you just need a different study design. And I think doing a study design where you drill down into Black populations, like some of the most beautiful studies in cancer epidemiology are actually group studies of immigrant populations. Like there are these beautiful studies of Japanese Americans, like multi-generational Japanese Americans, looking at their breast cancer incidence. Breast cancer incidence is just historically much lower in Japan than in the US. And so they looked and this was mid-20th century. And so the genetic paradigm was very strong in cancer epidemiology. But then they looked at these first generation Japanese American immigrants who immigrated as adults. Their breast cancer rates were similar to Japan. The next generation, the breast cancer rates were a little higher. These are people living in California. And this next generation, they're still genetically all Japanese American. This third generation, their breast cancer is like the white people in California. And so that's the kind of work that it doesn't give you a specific estimate or tell you like exactly what's happening, but it's saying this genetic thing is not really what's driving these intercountry differences. Like there's something about the living conditions of people. And that really shifted the paradigm of cancer epi towards really looking at environmental causes of cancer. And so there's been some beautiful studies thinking about the African diaspora, thinking about immigrants to the US. And that's like a very specific study design. It can't get you like the perfect estimate, but it can help you understand, okay, maybe this isn't all just like genetic ancestry, like when we're seeing such big differences. And I think it helps point us in more the right direction and to take advantage of that heterogeneity. And I think also something I didn't talk about in this talk, I think the Black-white comparison often pushes us into a deficit model where it's like, what's wrong with Black people? And what's wrong with these people? And I'm like, which is not the question of totality. Like my friend Chanel Howell, who's an epidemiologist, does a lot of work on resilience and the ways in which communities really take care of themselves. Like, honestly, if structural racism were left on its own without any resistance from communities, like the disparities would be a ton worse. And so one thing I do like about decomposition is it lets you kind of also have like a negative effect. And I think in one of Igor's talks, he found that, the unexplained variation actually had a different sign. And I wanted to ask you about it, but I never got to it. Because often the decomposition, one thing it can do is it can say, well, actually, this facet is actually making the group better off than the counterfactual, even though this facet is making the group worse off. So in a decomposition, you could even have groups that look the same, but you could splice up competing things. And so, yes, I think within group studies can be super powerful for answering a certain type of question, and sometimes really shaping paradigmatic trends. Qualitative work, I think, is really important. Like I kind of focused on a specific kind of work, but we just sometimes you don't know the right question to ask. So I think people get a data set. This is the data that's been collected. Are we even asking the right question? Like sometimes you need to just talk to people. You need to really understand their context. And sometimes people will bring you things you never thought about. And often we as researchers, we exist in our ivory tower and we could just be totally missing things if we're not really engaged with people and if we're ignoring qualitative work, and we could just be asking the wrong questions, which is bad.